and he is also author of many papers in endoscopic ultrasound, and he has received this year the Master Endoscopy Award from ESGE.
And finally, artificial intelligence. There are more and more studies occurring in the literature, and this was published in recruiting 12 endoscopists. 6 of them performed US with AI. 6 of them performed US in conventional mode. And as you can see here, AI was very nicely done, and they orientate the lesion and probability of being carcinoma was very high. And in this situation of neuroendocrine tumor, the probability of adenocarcinoma was lower. So putting them together, the difference was seen without AI and with AI only in in training endoscopists. But with AI, it was 91%, even better than in case of experts endoscopists with this one. But it's very important which model of AI they use, because here they trained very well the model with internal settings, with external settings, and we wait forward to see more systems which can be helpful for the future.
This patient has a neuroendocrine tumor non-functioning that is less than 2 centimeters in size. We know that this kind of tumors can be safely observed, but during follow-up, in this case, we saw an increasing size. And increasing size is an indication to surgery, but if the size is still less than 2 centimeters, we can offer to patients a less invasive treatment. And in this case, we are going to use radiofrequency ablation. Of course, the advantage of radiofrequency ablation is to destroy the tumor without surgical intervention, but we are not able to treat lymph node, so we must be quite sure that the tumor is not an aggressive one with a higher risk of lymph node dissemination, for example, as it happened in a tumor larger than 2 centimeters or with a G2 on biopsy.
So when and how to do this endoscopic necrosectomy? Not all the patients will need necrosectomy at the end. We looked at our own data, and approximately 50% of the patients needed endoscopic necrosectomy. Typically, this is the patient, and I'm always surprised because it's almost always the same clinical scenario. The patient improves after your drainage, but then after 3-4 days, the patient comes back in again with fever and increased inflammatory enzymes, and this is the patient where you will need to do a full endoscopic necrosectomy. So in general, what we do in Ghent, we schedule the patients already after 1 week. So we do not perform it right away. There are some data suggesting that you should wait at least for 1 week. And as I told you, 50% eventually will not need it. But then if the patient does not come in the next few days, then we just cancel the procedure and we do watchful waiting. Several tools on the market to perform your necrosectomy. I still prefer the snare after having tried a lot of instruments. It is obviously time-consuming. Necrosis can be very sticky. Everyone who performs it will agree with me that this is not something that you can schedule in 15 or 20 minutes. And sometimes you need multiple sessions. You see that the scope is often blurred by the necrosis. And this is what you should aim for here. And then on the left side, you see this is the wall. This is a clean wall. And you see at the end of the wall of necrosis that we still have some work to do. Once you start necrosectomy, you have to complete it. Because as long as you will have infected necrosis inside, the patient is at risk of having fever again and infectious syndrome again. In terms of complications, there was some major concern during a trial that was run in 2015-16, where they compared lumen-opposing metal stents with double pigtails for drainage of peripancreatic fluid collections. And it turned out that there were quite a lot of adverse events, mainly bleeding events, in the group that received lumen-opposing metal stent drainage. And the reason behind it is that lumen-opposing metal stents do not tend to migrate easily, so they tend to stay in place. And after resolvence of your walled-off necrosis, the wall of the walled-off necrosis will finally get in contact with your lumen-opposing metal stent, with the distal flange, and this might erode blood vessels, creating pseudoaneurysms and heavy bleeding. So the authors of that study, or of that paper, they realized that they should monitor regression of the collection, because all these events, all these bleeding events, they occurred after resolution of their walled-off necrosis. So they realized that they should extract the lumen-opposing metal stent in a timely manner.